We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 207. And this is the Retina session 59. This is the masterclass by Dr. Manish Nagpal, sir. And he'll be taking a lecture on complex retinal detachments. And he is the person who's been maintaining the precarious balance between ophthalmology and photography. So over to Dr. Lalit Verma, sir, to please introduce Dr. Manish Nagpal, sir.
Thanks, Rolika, for this opportunity. Manish is a very, very dear friend. He's a very accomplished retina surgeon. You see, what people think of starting, he has already done it. So I have seen, you see, whether it was, surgery for BRVO, CRVO. I remember, you see, he will put on these videos first. Whatever surgeries I have, seen his videos so often. You see, I remember CRVO surgery he used to do and showed wonderful results also. And very good point about him, which I learned after visiting Retina Foundation, was very, very daring surgeon. You see, at young age, to, touch these cases of severe PVR and doing all those retinotomies, retinectomies. Honestly speaking, we lagged behind Manish at that time. Now, a lot of us are picked up, but he was the person who showed the entire, ophthalmologist that these cases are doable. You see, the more bad cases you do, the more you learn and teach also. And as Rolika was saying, one of the other passions is apart from natural and wildlife photography, is his fundus photography is awesome. Believe me, his videos are so clear concept. In fact, so many times, a lot of people have asked me in physical meetings, sir, कैसे बनाते हो आप ये? So he will say simple answer, usual करता हूँ, वही contact lens है. But believe me, something he does which maybe he does not tell. But believe me, his videos are fantastic. In fact, I have been thinking for a long time, Santosh, to visit his facility and see how come he, prepares such nice videos. Not for the first time. Now I know a lot of people do good videos, but for decades back, I have, questioned this. And once you see those videos, he makes the retina surgery looks like so simple that kal main hi kar lunga is case ko. That is what his videos. Therefore, his videos I have seen a lot of his fellows also who have been trained under Manish, and they speak so high of him that sir teaches quite a bit. So see, because of his high quality videos, he has won so many prestigious awards. You see, one of them listed here is Red Macular Award, which is 5 years in a row. I do not know of any other person who has 5 years in a row. I think congratulations, Manish, and we are very, very fortunate to have you here. And this series of lecture designed by Santosh on behalf of Center for Sight. In fact, the entire CFS family is excited to have you here. And I, on behalf of Dr. Mahipal, Dr. Santosh, extend a very warm welcome to you and invite you for this very complex topic. Looks very simple, but believe me, I know Manish will make it very, very simple. But it's a very, very daring kind of surgeries we are hoping to see. Thank you, Manish, for joining, and you can share your screen now.
Thank you so much, sir, for all the kind words. It's a pleasure to be here. Thank you for the opportunity. I think a few years back also, Santosh had connected with me, and sometimes I think our times didn't match, and it couldn't happen. But I think fortunately, this time it should be fine. Can you see my screen now?
Yeah.
Okay. So I'll be talking about retinal detachments and take you from stepwise from a bit of basics to complex cases and talk about vitrectomy being done mainly because that's what we use today. Also show a bit of buckling, which we do in a modified manner using the vitrectomy-based viewing systems. A bit of GRTs and of course PVR. So I'll just take you through these step by step. And I think at the end of the talk, questions we could take up as they come. So when we talk of detachments, basically we all know it's a regmatogenous variety that we are discussing, and there's always a break or a tear which causes it. And there are a few ways of managing retinal detachments. The gold standard has been sterile buckling in the past, but today, if you ask me, everything has shifted to vitrectomy, except for certain indications young children, younger people with very stiff attached vitreous, single holes, inferior detachments. Those people, we still prefer buckling, but it's a dying art, and slowly it's difficult to pass on to because the numbers are going down. And I think vitrectomy is what is gaining a lot of interest, especially because of technology, visualization systems, and a lot of other things. Pneumoretinopexy is there for a very limited indication, a superior single tear with a bullous RD, it can work, but very often, if there's a wrong selection or the patient is not cooperative, has not done positioning, doesn't work that effectively. So these are the options that one has for managing these. So we'll start with vitrectomies, and today we all do trocar cannula based surgeries. This is 25 gauge. There's 23, there is 27 now. So various people are exploring avenues. Personally, I like to do almost everything with 25 at this stage. So when we start a vitrectomy, a primary vitrectomy for a detachment, our first aim is to remove the vitreous. And once we remove the vitreous, once we start removing the vitreous, we have to also know that is it attached, or is it is the hyaloid attached or not, is important, because sometimes you'll find eyes which have liquefied vitreous and the hyaloid is almost detached, and it's easy to remove all that. But at times it will be well attached, and you have to figure out how to go about. So this is a case where I'm just showing that there is a loosely adherent liquefied vitreous which is there, which is being removed, and you can totally remove it and then do the next steps. While in a case like this, there is no pre-existing PVD, and in a detached retina to create a hyaloid removal is more difficult than in an attached retina, because you don't have a good hold over the attached retina, because in macular hole, macular puckers, the retina is attached, and when you pull on the hyaloid, the retina keeps itself in its place while it allows you to pull. But here the retina itself moves away. So this is an example where in such a case, it's a good idea to stain with triamcinolone, and then so that it helps you identify the exact plane, and that way you have less chances of making iatrogenic breaks if you are pulling the vitreous with a very high suction in this situation. This is another similar case. I'll show you various cases, various steps with some repetitive things, so that it's easy for you to learn exactly what step I'm trying to do. So after doing a core vitrectomy, inject the dye, inject the triamcinolone, and then go to the posterior area and try to find any plane that you see between the triamcinolone stained vitreous and the retina, and then start to do a kind of a pull with a high suction. Every time you hold a triamcinolone stained vitreous, you will feel a resistance on the port, and it tells you that the vitreous is engaged, and that's when you pull. And as it keeps getting pulled, you can use the cutter to remove it. This is a high myopic detachment in which, again, the vitreous is adherent, and you can see that how the stained hyaloid, even if it's a small area which is stained, it's enough for you to know the plane, which is the most important in these cases. And you will see how the vitreous moves, the whole sheet moves, and it allows you to segregate it from the surrounding areas, and that way you can avoid any iatrogenic breaks in these cases. And then slowly keep on going from posterior to anterior, and you will see that as the hyaloid peels off, a whole ring of hyaloid will peel off, and then the retina will become more mobile in those cases. For vitreous removal in phakic eyes, just a tip that I wanted to give you, that in these cases, it may be a good idea because you're saving the lens and you want to shave the periphery. So here you want an external indentation. So you could either have a very good assistant who can do it for you, or you have a chandelier light like I've put in this case. And then I use my other hand to indent with an indenter and bring the peripheral retina closer to the posterior area, to the central part. And you could lower the IOP here to about 10 or even less than that to some extent, so that it allows you to indent a little easier. So in phakic clear lens eyes with detachments, this may be a way to go, because otherwise, when you go to this far periphery to remove the vitreous, there is a chance that you may touch the lens, and that can create its own problem. So this is in a clear lens phakic eye. Once the vitreous is gone, our next step is air fluid exchange, and this is a simple way of seeing it. You just switch it to air, and then let the whole air fill in, and the fluid will go into the breaks, and the bullas will come up like they came up here. And once the bullas have come up, then you go and find the break and endo drain from there using either a cutter or a soft tip or any instrument of your choice. Sometimes a passive one also you could use. Either way, your aim is to drain the fluid under the retina. If you cannot drain from the break, you could make a retinotomy based on the ergonomics of where the break is. Now, in this case, you can see that there is a detachment peripherally, temporally, and there's a break in the periphery. And after I've done an air fluid exchange, the fluid did not go up to the break. And so I put in perfluorocarbon to push the fluid to the periphery, then aspirate, and then do the laser. And I'm indenting and checking if the laser is all around. Otherwise, I have to top it up at some place. In the Macula ON RD, after doing vitreous removal, I will always put in perfluorocarbon because that kind of keeps the posterior pole always intact. Because you saw that when we do air fluid exchange, the bullas come up, and that's when the macula can get detached in these cases. So it's a good idea that you put in perfluorocarbon, keep the posterior pole flat while you look at the breaks in the periphery. And once you have the breaks in the periphery, the fluid in the periphery, you could go and aspirate endo drain from there instead of coming to the macular area or posterior pole. And now you can see that the retina is flat. And once the retina is flat, you remove the perfluorocarbon and you're set to go. Now, this is just to show you turbulence. If people are using non-valve cannulas, this is what can happen, that you have PFCL inside, and when you're doing maneuvers that I just showed you, every time you come out for any change of instrument, that's the way the retina has turbulence in those cases. So the valve cannulas make a lot of difference. See, here I injected, it was okay, but as soon as I took out the instrument, you can see that there's so much turbulence coming in, which can cause fish egging, which can cause PFCL to go behind in the retina at times. All kinds of issues can come up with this turbulence. And once you have the retina settled, the next step is doing some sort of retinopexy. So you will do an endo laser, cryo. Laser is the most preferred way that we treat them, but sometimes we use cryo also if it's too much in the periphery or you are not able to reach, especially at 10 o'clock, 11 o'clock. These areas, sometimes your instruments, your laser, you cannot reach as ergonomically in a phakic eye at times. So I always have a cryo lying somewhere in the next room, and if there's any need, I would call for a cryo, and instantly you see that the cryo, wherever there's a camouflage break, especially in high myopics or any such cases, the cryo works quite well in those situations. At times, if it's a very small break that you are not able to see, you can also do something what we call a cryo search. So this is the classic type of situation, a myopic eye with very strong tessellations, and a very small break is always missed in these kind of eyes in the periphery if you're not seeing a posterior break. So here I'm indenting, and at a point that I suspect the break, I'm using the cryo, and you can see the slit, how it has shown up so well, and it's also the retinopexy is achieved. So cryo is not something which should be thrown away in a vitrectomy. A lot of people feel that only laser is the way to go, but I think it's a great tool to keep on hand for vitrectomy also. Now, this is a superior detachment with the macula on status, and you can see that once again, after doing vitreous removal, I've put some perfluorocarbon so that the macula always remains flat. There's no point that when I do the air fluid exchange that the bullas will reach the macula. So that's extremely important for all these kind of cases when you do a vitrectomy in those situations. Now, this is a case of detachment with a posterior break as well as a macular hole. So you see a posterior break, which is also seen in the same field, and a macular hole. So here, I would also add an ILM peeling to it, so that it will help secure the macular hole as well, apart from doing the regular things that we do for a detachment case. So I've stained with brilliant blue and removed it. In this case, I'm putting PFCL now to push the fluid to the periphery, and then aspirate from the posterior break which was there to flatten the retina. But at times in a detached retina with the macular hole, we put PFCL to stabilize before peeling also. So I would always start without PFCL. If it allows me to peel well, I would go ahead. If not, I would put perfluorocarbon in that case. Now, this is a case of actually an old vein occlusion, which led to a detachment tegmentogenously and a macular hole you can see. And you also see a few sclerosed vessels. So it's not a tractional per se based, but at some point the regmatogenous component took over after the vascular occlusion. And here you can see once again, there's a macular hole as well as a pucker which has formed peripherally. And here I extend the peeling towards the pucker because they're very close to each other, and we need to reduce the traction as much as possible for these cases whenever this happens. So you can see that I'm peeling. Now I'm kind of loosening the puckers, trying to find, these are ill-formed puckers where you will not see a formed membrane at times, but as you go and pick up on the center of these puckers, usually some sort of a membrane would come off, or an ILM would come off and would release the traction. Then we go to more larger tears that you see here, extensive. These are classic PVD-induced tears. You will see them, multiple tears coming up. Also, some time has passed, so some PVR changes have started, and the tear edges have unfolded onto themselves. Large vessels are also bridging over them. So you can see that if there is a vessel bridging, what I do is I diathermize them, because sometimes it will just start a bleed, which will nag you through your viewing and would bother you through the surgery. So it's best to secure it before you do the other steps. And so here you see that I've injected perfluorocarbon to just allow me to flatten till the periphery, so that I can assess well, also flatten and also iron out these folds which have formed at the edges of these breaks, so that the retina is stabilized before I do a laser around it. So once these folds are well secured, then do a laser to these areas. There's another similar case, a PVD-induced large tear you can see. So the vitreous removal is being done, and multiple tears all around, as you can see. And once I remove the vitreous with multiple tears, I like to put perfluorocarbon so that the posterior pole is well secured, well attached, go up to the periphery till the breaks are there, and then do a good drainage and then do the laser at that point of time. So it allows the posterior pole to never get these folds, because at times with these large tear, a lot of fluid, you can get folds in these cases, which can be residually present. From this, we go on to a few cases of giant retinal tears, because they are also detachments, except that we call them giant retinal tears, and if they've got a few different peculiar things on how we manage them. And I think visualization is the key to a good success in these cases. And the game changers have been wide field viewing systems and perfluorocarbon heavy liquids. And for both of them, we need to thank Dr. Stanley Chang from New York, who was instrumental in introducing both these things. He introduced the RV viewing systems. Now we have many systems, but his first one, that contact-based thing, RV, was what was induced, and then perfluorocarbon heavy liquid. His work was instrumental that we are all using this heavy liquid today. So with these two things, everything changed for the management of giant retinal tears. So a few cases to show how these tears are managed, and you can see that there's a large tear which is just the flap has overturned onto itself, and in these cases it's mandatory that you make sure the vitreous goes away totally, because Otherwise, it will keep on creating problems. Also, the peripheral edge that you see right now in the footage, that the vitreous is attached to the peripheral edges of the tear, and you need to remove the vitreous as well as trim it, the tear edge as much as possible in these cases. So remove the vitreous all 360 degrees, and once you are reasonably sure that the vitreous is gone, then you would want to open up and see the unfold the retina rather, and put so that it kind of in a passive way goes back, and imagine how we could do this without PFCL. It's almost impossible, and that's why in the era before PFCL, there used to be all kinds of antique based surgeries for giant tears. The patient used to be turned upside down. Surgeon used to sleep on the floor and operate and all kinds of things. Luckily, we don't have to do all that. But perfluorocarbon is the magic tool. Just passively unfolds, pushes it back. So what I typically do is I fill it up to a certain point on the equator, and then again look for some peripheral vitreous, because it allows you to take away some more vitreous, then fill it up to the brim, then do a good 360 laser to these. And then how I do it is first shift to air, an air PFCL exchange, and then as a second step shift to oil, while a lot of people also do a direct exchange in these cases. So either of them could be done. I personally have been fond of this one. So here the trick is that you have to keep the edges dry. So when you do the air fluid exchange, unlike in detachment cases, normal detachment where we go to the disc and finish the exchange, here don't go to the disc. You have to go to the periphery, keep the edges dry, and at the end go to the disc in these cases. So I'll show you in a few more cases so that you can understand what I'm trying to say. This is another case you see with a ragged folded edge of the tear, which is there, multiple smaller tears also. So these are patients which are prone, they have weak areas, and once the PVD or the hyaloid pulls off from somewhere, it creates a huge tear. So the same steps, except here that again, as you can see that I'm removing the extremely peripheral vitreous and the peripheral edge of the remnant of that. And then once you do the exchange, here, this is what I was talking about, that keep all the edges dry, and you can do it only if you are viewing it well, and that's where the wide field systems come in, because if you cannot see that area, you cannot keep it dry, and you cannot watch it in that. Now this is a traumatic post-traumatic giant tear that you see here. Is a patient who came to us with trauma, and similar approach, nothing different, but it's just the etiology is different, and it was lasered by somebody in the periphery when it was just a tear. But of course, giant tears don't always stabilize with laser also, because they have a propensity, they have a large mass, and they very often will break through the laser marks and go through. So here once again, we are doing, after the laser, doing the exchange, and you can see that I'm patiently watching the periphery to the edges, making sure it's dry before the PFCL leaves the edge from that particular area. And at the end, you see a nice flat retina with 360 laser with air inside, and then put in oil, which can be removed after 3 to 4 months. Now, this is a tear which is almost folded onto itself. It's not a 360, it's got a small attachment inferiorly. And eventually you would realize that as I open it up, I realize that because it's getting contracted, that inferior attachment is no more beneficial, because it adds to a bit of contraction in that area, and leads to problems. So as soon as I'm able to unfold it a bit, I assess after putting in some PFCL as to stabilizing the posterior pole, and then I realize that there's a contraction inferiorly, so I decide to convert it into a 360 degree. So this is a call you have to make in some cases where the contraction may otherwise lead to a problem. But suppose it was a fresh tear and it could, if there was no contraction, you didn't need to do this maneuver, and you could have kept it some part of the retina attached as it was. Lastly, wanted to share in giant tears this case of a young kid who was a one-eyed patient, again post-traumatic, and came to us with this giant tear, 360-degree, high myope. And as I started the case, removing the hyaloid vitreous, and I realized that this young kid, about 8 to 9 years old, had very adherent vitreous. And now I was discussing with you in detachments, it's difficult to remove hyaloid because the retina keeps moving. And in a 360 giant tear, this task becomes all the more daunting because not only is the retina detached, but there is no whole 360 degrees in this. And every few minutes, the PFCL which I injected would keep on going behind. As you saw, again, I put in some PFCL and was pulling on the vitreous, then again the PFCL has gone back. After that, I put in a chandelier and I took another instrument, a massager we call it. We use it for macular holes or also for any maneuvers where we need a second hand or ironing. And I use that. If you can see on the left, my left hand instrument is a massager which kind of helps keep the retina at bay while I'm pulling. You can see that I'm holding onto the retina with that instrument while my cutter is pulling the hyaloid, and it's in a very what can I say, a precarious manner that the retina keeps on getting pulled, and again the PFCL can very easily slip back. So this is a case which had 3 or 4 times that the perfluorocarbon did go back, but eventually I did manage to get it off gradually, going 360 degrees by using this maneuver, gradually peeling it off. Because unless you get this off, there is no way the case would be successful in the long run. And I'll just fast forward for the sake of time, and slowly I could get it all off. And initially, once we got it off and put more PFCL, we saw the retina had turned down because it's a 360 tear. So gradually we rotated it back using the same massager towards to a normal area, relocating the macula and then doing a 360 laser, as you see. So some of these cases, giant tears, young patients, can be extremely difficult. Again, I'm doing the exchange which I told you about, where you have to be careful keeping the edges dry, and 360 degrees keep it dry. As the PFCL leaves that edge, then you can go and aspirate it totally. So this video actually last year won the 3rd place in the American Academy's global contest on challenging cases. Now, let me take you quickly to a few cases of buckling, which we do in a certain group of cases, especially young children, dialysis, those kind of cases. And we do it differently in the sense that we do a classic buckling procedure, but we use a vitrectomy lens. I use a contact-based wide field lens, which you saw in all my surgeries. And then using that and putting a chandelier light, we use the same visualizing system as the vitrectomy and then do a classic buckling. So if you look at these sequential pictures, the chandelier is put just like we would put for a vitrectomy surgery, and then put my contact lens on, and then you can get a view just like you get with vitrectomy inside, except that you're not making 3 ports, you're not going in with a cutter, you're doing a classic buckling in these cases. So this is a case that I'm showing you of buckling, an inferior, a detachment that you see here in the myopic eye. I'm indenting from the periphery to look for the break. And you can see the cryo coming up. After that, you can see that I'm taking a suture at the localizing break, putting the buckle, doing diathermy to the site of drainage. I do it with a needle, and you can see the fluid coming out. So all these steps are of a classic buckling surgery. And at the end, look inside to look at the flat retina, and then look at the indentation once you put the buckle. Just like how you would see with an indirect ophthalmoscope normally, but instead you are looking at it with a vitrectomy-based system. So these are the steps. You locate the hole, you do a cryo, After that, you localize externally, drain and put the buckle, and see the buckle effect in these cases. One more case example I'll show you of inferior breaks with an inferior detachment. You can see here the advantage is that you can, with vitrectomy based viewing, you can see very well. You can zoom up the tears or the holes, and also for teaching, it's a great tool, because with indirect ophthalmoscopy, it's difficult to teach or show to your fellows what you're doing. With this, the visualization is same as vitrectomy. So you can see that we've localized, we are doing cryo to the breaks that's there. After that, we've put in a localizing suture at the buckle, draining, and you can see pigments coming from there. And the fluid is draining out, and we give pressure to the posterior tip of the drainage site so that all the fluid can get evacuated from there, and then look inside. Once the drainage is done, now you look at the buckle effect. The tears, the breaks which you saw are well on the indented by the buckle in this. So this is something that we had we have been doing since 2011 and published it a few times. Also spoke about it at the Whale Vitrectomy meeting in the past, and now I think a lot of teaching institutes have adapted to this. Even the Duke people got back to me about how they are using it now for wherever they do a buckling, they are using chandelier-based buckling. And I think converting to this is not very difficult for a vitrectomy surgeon who's familiar with buckling, because the viewing is the same. It's just one has to put a chandelier instead of putting a indirect ophthalmoscopy based technique. So let's go on to the last part of the talk, which is going on to more complex PVR cases. In this, we've been publishing a chapter of PVR in the Ryan's Retina in the 5th edition, 6th, and now the 7th one is also ongoing. I think anytime it should come. So PVR is something that is kind of a bugbear for detachments, and a normal detachment which you can manage gets complicated. And PVR can be as simple as having a pucker or folds or wrinkles coming up following a detachment. And the more time a detached retina has before it gets operated, more and more of these changes come up. So this is an example of a pucker which was there. We removed, and in cases where there are puckers, it's now believed that one must also go ahead and peel ILM, because it would reduce the contraction and maybe reduce the chances of a recurrence that may happen through these areas. So in these cases, apart from doing the normal steps of a detachment, you would first remove all this and then go ahead and do your normal stuff. Now, this is a case where you don't see a well-formed pucker as you saw in the one before, and so here one would stain and remove the ILM in that area, because very early formation of a membrane or a pucker would be there, even though you don't see. And when you remove the ILM here, as you can see that once the ILM is removed, I'm flattening it with the PFCL to further expand the diameter of the ILM, because there are radiating folds from there. So once you see PVR changes, you may have to look for these membranes or folds which are there. And you can see here that as we move, you can see the membranes or the ILM coming up, being peeled off, and then the retina looks healthier and better in terms of the wrinkling and the folds as we keep on expanding it. So this is a technique that Stano had taught us, that you stain with the brilliant blue and look for these in PVR cases, especially early PVR cases which are there. Now this is a case with a stiff kind of thickened macular pucker post-trauma, actually post-foreign body removal. Actually, foreign body was inferior but had formed a whole path of this traction, right? Very thick pucker in the macular area, and you can see it was radiating down that whole pucker to the inferior 7 or 8 o'clock area. Once, as soon as we reached that area to laser, I realized there was still a traction. So we did some diathermy and did a small retinectomy to relax that fold, because this kind of a thing, residual traction may be fine during the surgery, but post-operatively it is bound to create contractions and peel off. And the retina will pull off from there. So the staining I showed you, these are classic cases where you see a lot of wrinkling all around, and you will not find well-formed membranes. So you inject a brilliant blue dye, and after that you put in perfluorocarbon. After you remove the residual dye, put in perfluorocarbon and fill it up. And then under perfluorocarbon, kind of peel off the ILM or the ill-formed membranes which are there. So you will see here that sometimes I also use this finesse loop, which helps you identify these ill-formed membranes and the stained membranes, which briefly stain with the ILM basically, but the ill-formed membrane comes off with the peeling also. So it's a great technique actually. Put in, after removing vitreous, put in brilliant blue, remove the residual dye and put in perfluorocarbon, and then try to peel off these areas. And the retina settles quite well after that. This is again a case like you can see a much more wrinkled retina here than I showed you in the previous case, and you can see that we first remove the whole vitreous component which is there, so that we are sure that the retina is freely mobile. This is the tear that you see here, and once you've done that, you explore for any obvious membranes which are there, and you can see that posteriorly there is a membrane which we are peeling, and as it gets peeled off, there is some relaxation of the posterior retina which is noted there. And after doing that, put in the dye, and once you put in the dye and put in perfluorocarbon, it will actually become easy for you to sense or see these areas, because as the ILM is stuck to these kind of ill-formed membranes which are on top of it, so the ILM will come off, and along with it, all the ill-formed membranes will come off. Because otherwise, I would never peel in primary detachments without puckers or without PVRs. I never do peeling in all detachment cases. It's only in these kind of cases where you see PVR changes, wrinkling, or ill-formed membranes that I think it works well. Now, look at this contraction here. You know, as we peel the ILM, you can see a whole circumferential contraction where the ILM is, and it does help relaxing that whole component of the detachment, and goes a long way in ensuring that post-operatively the flattening may be better. So a little more complex case, a few cases that I'll show you here. Once again, you see a thick pucker which is formed posteriorly, and how easily at times it looks bad, but sometimes these thick puckers are the easiest to handle, and you saw how it came off and suddenly the retina goes back. And this is a much more extensive traction that you see all 360 degrees with chronic kind of folded edges of the brakes which you are seeing here. And the aim is again to remove all the vitreous and a bit of the hemorrhage stained vitreous which is there, and using all kinds of means, cutters, forceps, bimanual. Like here now I've shifted to a chandelier with the bimanual at times can be useful in these cases, or use the light pipe as another hand where you pull the membranes with that. So these are personal choices. People use various types of tools to make sure that the periphery, you can remove and relax the retina as far as possible by indenting and removing these areas. And then, of course, again, the same way, testing with brilliant blue and PFCL at times to peel off all the posterior pole areas which can create traction. So this is a case where we started off looking at this extremely thick traction that you see temporally, and you can see hazily the disc first, but there's a lot of interior PVR, And the first step is, of course, to remove as much of vitreous as possible, put in a bit of PFCL to understand where the traction is, then gradually try to remove this epiretinal component. And once you realize that that's no more effective and you may need to do a retinectomy, that's when you do a diathermy and start cutting the periphery. Make sure for retinectomies, the best thing is that make sure you have a good PFCL, which is stabilizing the posterior pole, because at times it may bleed, and the PFCL helps you keep the posterior pole stable. Also, if a bleed happens, it does not reach the macula right away. It gives you a lot of time in these cases. So here, gradually, we keep on increasing the retinectomy edges, because the retina is almost 360 degrees contracted. We always do it in a phased manner, because in some cases you may need a small retinectomy, but in some you may end up needing it almost 360 degree, like in this case. And you can see that I call these like kind of geographical maps, these kind of cases where you end up making some map of a country, the way it goes, and then it's a 360 relaxed retinectomy, and this is how it looks like immediately post-op. And after a month, the patient was seeing about 636 vision after oil removal. So at times it can be quite useful, and especially in one-eyed patients, I think these kind of maneuvers are great. This is a case of a giant tear with a very posterior tear as well as a macular hole. So here, the thing what I wanted to show you was after removing the vitreous, we peel from the hole, around the hole, and then go on and extend it up to the periphery, because here the edges of the tear are so posterior that there's no point leaving that area, because it will add on to a contraction. So extend your peeling of the ILM up to the edge in such a situation, so that you get as much surface area of retina, which is less because of its propensity, because it's very close to the macular area in this case. And this is a large retinectomy inferiorly. You can see a very thick, shortened, contracted area. We remove some membranes first. Your first aim is always to do membrane removal epiretinally and then assess the traction. So once you have removed the epiretinal component, you can go and then decide how much retinectomy is required. So once again, diathermy is done, preparation, and then we cut the inferior retina using that. Let me take you to one or two last cases as the time is running out. So this is a case of PVR where there's a redetachment in which oil was there, and we've removed the oil, and there is also subretinal oil in this case. So you can see puckers in the posterior pole, and there is oil which is trapped in the subretinal space inferiorly. So our first aim is that I put in some PFCL because that's always useful, then remove this pucker, which kind of flattens the retina. And then you can see that the trapped oil globule inferiorly suddenly gets released and it comes out, allowing you to further relax. And then you'd go ahead and do a good retinectomy, that the same manner that you do diathermy. After that, you again check for any residual bleeders and do a diathermy in that case. This is the last case, again, a chronic myopic redetachment with multiple times operated, and again came back with PVR and subretinal oil. And you can see here that there's also neovascular process going on inferiorly because of the chronic nature of the condition and the oil globule which is trapped here. So we anyways make a retinectomy and release the globule of the oil which is trapped inferiorly, and it comes out, and then assess for the residual traction which is there, and gradually keep on relaxing as per requirement. And you can see that the whole aim is to make sure that the posterior pole is well flat and the peripheral traction does not go there. So for that, if you need to sacrifice peripheral areas, at that time you make a call and do as much as possible. So these were the last few were the more complex tractions, wherein I think you needed a large area of retinectomy done. But in most situations, it's an inferior retinectomy because PVR changes, contractions are located in the PVR is located inferiorly most of the time. So I think these were a whole array of cases from the basic steps of a primary vitrectomy for retinal detachment to going on to a bit of buckling and then going on to chandelier-based systems. I mean, in how we modify it, and then PVR cases to see some of the complex steps. And I think it's a learning experience, and I still keep learning from various cases, various people that I see. There are some tips that you'll pick up from everybody that you see. So keep seeing people at work. I think it's the most important way to learn. I have a lot of videos on my YouTube channel. Keep posting as and when I make some new videos and put them across. Also, I share on my hashtag InstaRetinaRF on Insta very short, less than 1 minute videos to show various steps. So please feel free to visit that. And lastly, of course, this is beyond ophthalmology, and hashtag precarious balance is where I share my stuff related to this particular book that has come out. So I would be extremely happy for you to visit this or maybe get access if you can, and would love all the feedback that you can give me. Thank you very much for having me here, Santosh, CFS, and Dr. Lalit, and the whole team here. Thank you so much.
Thank you, Manish. I think that was wonderful.
Hello,
Thank
sir.
you. I must say, videos, excellent job done, I must say. And there have been a whole lot of questions which have come up. In fact, I also have penned down huge number of questions.
Okay, I'm happy to answer.
I was telling the audience that what you saw was just the tip of the iceberg.
Hello, I think I lost your voice.
Lalit sir, your voice is breaking.
Wonderful video.
Thank you, sir. Thank you very much.
From Manish. You see, as this
Traveling, so probably.
I think we lost the connection.
Yeah. Dinesh sir?
I think we can, when he joins us back, he can complete.
Yeah, sure.
I think we've seen the entire gamut of cases.
It's very important. So there have been some chat box questions, Manish, which you have to answer. ERM and ILM during surgery. Manish?
Yes, sir. So the question is what? I didn't hear.
No, this question was that how do you differentiate ILM and ERM during surgery?
Oh, okay.
Okay. Who have RD.
Okay. So ILM and ERM, how do you differentiate? So ERM is something, I mean, you will, like there's a pucker is where you are looking for an epiretinal component. In normal detachment, see, ILM is there always in retina. So if you stay in it, you will always see it. So I don't recommend that somebody tries to identify and peel something in a detached retina which they think is an ILM. So never do that. Always use brilliant blue dye if you intend to peel for any reason. And ERM is something you may see, like I showed you in a few cases, well-formed puckers. You know where they are, and you go and find the edge, or use a finesse loop or a Tano scraper. So wherever you see kind of a star fold, that's where you need to explore for a membrane. And the cases where I showed where the dye is used, where it's an ill-formed membrane, where there's only wrinkling type of PVR, where you don't see a well-formed membrane, but you are seeing a lot of wrinkling, which is not looking good. That's when using a dye to just look for the ILM is a great idea, because as the ILM is peeled off, any ill-formed membrane, which is obviously going to be on top of it, will also come off from that area. So that's how I go about looking at.
Are you very particular in peeling ILM in a lot of your reg RD patients?
No, I only peel. That's why I was stressing that I don't peel ILM for 90% of detachments. It's only when I see a pucker or I see a wrinkling star fold which has ill-formed, which doesn't show a pucker but has this ill-formed wrinkling kind of nature, is where I would look for an ILM to be peeled. But in normal detachments, I don't do that.
The second question is that you mentioned about that IOP should be lower
for indentation, sir.
And one question which is asked, which is I think a simple answer is how much IOP do you keep for air fluid exchange?
So IOP is between 25-30 for my even for my fluid when I'm on infusion. Around 25 to 30 is what is my standard one, and when I switch to air, I keep the same. Only time I would raise it is if sometimes there is a lag when the air comes and you want it to come fast and you are impatient, and I step it to 60 for a second on the foot pedal and then go back to 25 or 30. But technically, it's always 25 to 30 for exchanges also.
The third question, Manish, is that why is retinectomy done to relieve traction?
Well, so because for any PVR case, the first thing we look for is one is what you remove vitreous, you remove the hyaloid. So that is one part of the area that you've relaxed the component. Then you look for an epiretinal component, which is membranes or puckers or anything which is visibly seen, or you explore it in the areas where you see a traction and look for them and remove them. After that, what you see where it doesn't flatten or there's a tenting is something that you need to cut, because if that remains, that is not going to allow the retina to settle, or if it is in an area which is still stiff, on table it may look fine, but post-operatively that contraction is going to build up. So then you need to take a call and relax that whole area, which more often is the inferior retina, as I was talking, because PVR contractions more often are inferior. Yeah.
So there, you see, the thing is, a lot of people today have very low threshold for doing retinectomy. That's what I am scared of, and I normally do not teach like this.
Yes.
See, first, like you rightly said, it's always membrane surgery, and keep doing that till the time you see a foreshortened retina but today a lot of younger people, specifically maybe Dinesh can add something to it, or Shrinivas, about this role of retinectomy. People resort to retinectomy very fast, Dinesh.
Yeah, so actually, Manish, I'd like to ask you, how do you decide that now this shortening is not going to settle in any other method? Like, for example, you've done it's a relatively bullous RD. You remove the ERMs, you'll find that obviously the retina becomes even more bullous because the posterior part is released. Yes. And you've shown very beautifully that many membranes which we think are inoperable are actually easily operable. Yes. So that's a very good thing, that you've shown. Now you've removed those membranes and now you've decided you need to do a retinectomy. So how do you reach that conclusion?
Yes, so very good question, sir. So when we do after vitreous removal and air fluid exchange, and as you mentioned that the bullas come up and the way they go to the the bullas line up towards the disc, and so that is a great sign to tell you that this case, the retina is very well mobile, and obviously there's no need for there's no shortening of any nature and will settle well. And so that is a great clue. If after that, if you are seeing that is not, the bullas are not coming up well in some quadrant, especially inferior or somewhere, you're already suspecting that, okay, this place may have a traction component. So there are two ways to look at it. One is that you still go ahead and try to do an endo drainage and you'll see an air bubble or something going behind. And that is a sure shot sign that please switch back to saline, put in PFCL, flatten it as far as it goes where you see the tenting stop, and then see that area and decide if at all there's no other epiretinal component to do a retinectomy and relax it. So that is the best way to do it. Or you could have, if you're already suspecting before air fluid exchange that there is tenting, you could start with, after vitreous removal, putting perfluorocarbon and gently extending it to the equator up to the breaks that you see, and then see how is the retina behaving. Is it flattening well throughout, or suddenly at some point, in spite of the weight of PFCL, it is still showing you a tenting inferiorly? Or so you know that if PFCL is not able to flatten it the way it should normally flatten, that means it needs, and there's no membrane there, that means there's a shortening or a contraction which will need a retinectomy. So I think these two ways are very quick ways to know.
At that stage, would you first try island peeling in the periphery also? Because, a lot of the Egyptians also talk a lot about it, and I find that actually it makes the retina much more pliable.
Right.
When it's looking like shortening, that stiffness often becomes less if you just do island peeling in the periphery. Sometimes that can help you to, prevent needing retinectomy in those cases.
Possibly. So the few cases I showed you where there are extensive wrinkling type of retina, so there I think the island peeling will definitely help. But if you are seeing a definite contraction, their island peeling may be so minuscule, its whole kind of advantage, that I would rather just isolate the clock hours that are stiff. Go. And other point I wanted to make is that when you do a retinectomy, make sure you go into 1 or 2 clock hours of relaxed retina as well. Don't just stop up to the tenting. Go 2 clock hours on both sides, because that's again a very crucial area which you feel on table has settled, but it may give way post surgery.
That was my next question to you. Yes. So you've answered that already. But you were very fond of mentioning that previously. And I think that's a very good way, that when you do the air fluid exchange and you see that there's a tendency for the air to go back, you can even do the retinectomy under air till the retina settles back.
Yes.
So, Manish, you said PVD is, creation of PVD is a very important component.
Yes.
Do you always stain with the tricot and remove? And sure, I would like opinion from Shrinivas also, and that because sometimes, especially in high myop eyes, we get misled that this, because the tricot moves very freely. And I think all of us have landed in that controversy, or whether to put tricot in all patients of reg RD to remove that hyaloid.
Absolutely. So I don't use it for all cases of detachments, but wherever I can say, once you go to the posterior pole and start using a bit of suction to test, I always do a testing suction in a safe manner over the disc, and you see a resistance coming there, and you know that there is a hyaloid which is attached. In that case, I would like to put triamcinolone, because no matter how visible you feel it is, in a detached retina, triamcinolone staining is always going to give you a better visualization of the plane at every juncture, because you're not just working in one plane. In a macular hole, in a pucker, you are at the macular disc and you pull it off and then you can see the whole thing moving, but the retina is always attached. Now here you may start feeling, you can maybe the posterior pole hyaloid may come off, then how it is going to behave in the periphery is not predictable. So a staining is always useful, because some granules of these triamcinolone everywhere would constantly keep telling you, oh, this is the place where hyaloid is attached, this is the place where hyaloid is attached.
I think the reason I asked this was, the reason, Manish, I asked this is because, especially in high myopes, it's always because that last bit of cortical vitreous.
Yes.
And sometimes you see it's always better to reconfirm, especially in high myopes, that even if few crystals stick, that means there is some part of hyaloid.
I agree. In fact, in high myopes, I would go to the extent of saying that even if you stain one for the hyaloid, maybe put a little bit as a second time, because there is this sheet of cortical vitreous which is which fools you. You realize it when you are actually doing some peeling there, and it will not work the same way as you are used to seeing.
And you showed very nicely cryo. You see, are you a very fond user of cryo in contrast
to
laser?
I always have it as a backup. In a minute I can get it as an excess. So anytime when I'm in a vitrectomy, especially, when I use it is when there's fine small holes around 10, 11, 12 o'clock, 1 o'clock, where the laser probes sometimes are unable to, your visualization is not great, or you're not able to reach it that easily. Or in some very high myopes, you can't see it also because it's so camouflaged. So that's when I don't waste time. I've learned over a period of time that, you keep indenting, looking, you are going to waste 10, 15 minutes. Instead, pick a cryo. Within a minute, you are sorted, and
I will take opinion from Shrinivas also. Laser versus cryo is a big thing, because a lot of people keep telling in various webinars that you see cryo, you may have more PVR, laser, you may have less PVR. So, Shrinivas, what is your preference?
A very pertinent question, especially when it comes to Phakics and it's a very peripheral break. Then in those cases, I usually prefer to do cryo rather than laser. I've seen many people having a lens touch or not localizing it properly. Indentation might be difficult sometimes. And extreme peripheral breaks, especially when it is phakic, my first choice goes towards cryo. And I don't believe that it's too inflammatory, whether it might cause PVR. Of course, you need to know how you can freeze thaw your.
Yeah. I don't think that the type of, for that one shot of cryo or two, it makes a huge difference about laser versus
Shrinivas,
cryo.
if you are doing direct kind of visualization, so that you can control the intensity very nicely.
Yes.
Yeah.
The other question which is very commonly asked is the role of belt buckle during VR surgery.
Right.
The question was that, Lalit sir, I just asked the same question. Manish sir, beautiful videos. So, so same coming to Lalit sir question. See, when you showed that extensive PVR video,
yes,
right? So in those cases, especially in some cases, we have a rim of vitreous still left, beyond which you are not able to induce the PVD.
Yes.
Of course, you have induced up to the peripheral, and the peripheral, that rim.
It usually happens. Yeah, I know what you mean.
Concentric kind of rim, where we can only try to trim it. Yes. And we cannot, the more we try to extend it with the forceps or the cutter, definitely the retina is going to tear. So in that, when you notice it on table, so do you convert it on table? You do decide to go in for the belt?
No, personally, I don't convert it into a belt buckle or something, because I think in the past, of course, if you ask me 5-6 years back, I was doing a lot of belt buckles for these kind of cases. But over a period of time, I think I just keep trimming it as much as possible and leaving it, and wherever required, do a retinectomy if it is more than what is desirable, not wherever there's stenting for all the reasons that we discussed. But I don't put a belt buckle in the middle of surgery for that reason.
Okay. And in how many cases of PVR you usually use the belt buckle, or you don't use at all?
No, I've stopped using now. But I am not recommending it. I feel that everybody has a learning curve with these cases, especially with the peripheral, managing peripheral vitreous, and a belt buckle is a very useful thing to have, because it will bring the peripheral retina a little more visible to you. It will reduce the contraction to some extent and help you. But today, at least I feel in my hands, I feel that I don't need it.
I think you go for retinectomy. That removes the need for the buckle.
At some point, yes. So, I agree. So maybe
once you've done a retinectomy, you don't need a buckle.
Yeah. But I would not. I'm not trying to give it as a recommendation for. I feel that everybody should start off with belt buckles, and in case at some point you are comfortable without it, you shouldn't. But I won't say don't put belt buckles for those cases.
Shrinivas, actually, I don't think the belt buckle per se makes a difference. I think if you really need a buckling effect, and that's usually in the inferior retina, then you need to give a buckle. So, and that would be generally in pediatric detachments. If it's a child or if it's a young adult whom I don't want to sacrifice the lens, that's where I would consider putting in the buckle.
Yeah, children, I think, are you have to make an exception, and at times you need to put a belt buckle or buckle something.
But
for those cases,
in adults, I think usually I would clear off the retina. Even if I may not do retinectomy. If I feel I can settle the retina, I would give a broad zone of adhesion with laser and cryo in the periphery, which is effectively the same as putting a buckle, actually, once it's settled back.
It's like, they say that you shift the aura posterior.
Exactly. You shifted the aura right to the equator. After that, the only thing you can get is posterior PVR, which, as you showed, is very simple to remove.
Yes.
A macular pucker will easily come off.
Yes, naturally. Posterior part is not difficult. It's this extreme periphery which is the problem.
The only real thing you're worried about is anterior loop traction.
Yes.
And if you've created a big zone of adhesion in the periphery, it can't go into an anterior loop. No. It can only, at most, it can detach a little bit, and you can always consider doing a retinectomy at that time, if required.
Absolutely, yeah.
And one more thing is about the use of finesse loop. Of course, I have tried, but I'm not great fan of it, especially when peeling the ILM on the posterior pole. But I saw you using even for the peripheral PVR also. How really it helps you? Because The simple ILM, sometimes it's so difficult to come. Whether this star fold, the fixed folds, will it really, the finis loops makes a difference?
Actually, I never use it for macular area at all. I mean, I've used it just to test it. But I just do a pinch and peel, so I've never used either a Thanos or this. But peripherally, I actually find it useful. I somehow feel that, because see, that's an area of retina where you can tend to give more pressure and move it. In macular area, you are anyways worried about going deeper, other things. Now, this is a peripheral area with some wrinkling retinopathy kind of a thing, and there you could give pressure and try to find the edge of a membrane. And also, if suppose there's no membrane, it kind of irons it out. It just, those folds just tend to iron out with that. So it's more for that, I think.
But in case of even detached retina,
Shrinivas,
no, but I do it under PFCL. I don't do it. So I would not do it in detached retina, because there I agree. If you give pressure, you might just create a break there. It will not, because there's a tenting. So this was whatever I showed you was
under the PFCL.
Under PFCL. There, see, PFCL has its own weight, and then you are using an instrument to just iron out. So sometimes you may see a small sheaf of a membrane or ILM something come off, or sometimes it'll just iron out.
I think basically the shaft of the finis loop, you don't want to touch the retina. So, so the finis loop per se, you can modify the length to decrease the amount of pressure you want to put on the retina.
Yes, you can,
or increase it.
Yeah.
But there are 3 instruments other than the finis loop, which I find actually change the entire surgery. One which I use is a 25 gauge MVR to create the edges of the ERMs, these puckers.
Yeah.
Once you've created the edge with this, the second thing that works very well is the spatula. There's the membrane spatula from Alcon, which is both in 23 and 25, and that can help you go in between and separate out the membrane very atraumatically. And the diamond dusted also works like the finis, but I believe it, since it causes less pressure, so and a little broader pressure, so it gives you a much more easier massaging of the retina to get away from the membrane.
Right.
These are the 3 things which together help you to pick up the membrane, the membranes from the surface and push them into the periphery.
Sure.
And the finis loop adds to the same thing.
Yeah, I think it's people can prefer any. I mean, these are all things available, and one has to figure out what works.
And basically use the PFCL to stabilize the retina at each point. You can keep on increasing the PFCL as much as you want, and keep on stabilizing the retina so that membrane separates out more easily. Yeah. So I think
the one thing I again want to stress, I've already shown it on all my cases, that I use PFCL for almost 90% of my cases, even primary detachments, simpler ones. I feel that it makes a lot of passive flattening possible, which is less traumatic than anything else you might do. And except for those very simple cases where the bulla comes up and you do an endo drainage, it comes down. But if there's anything beyond that, if I feel that the fluid is short of the break, or I would not just go ahead and make a retinotomy for that reason. I would rather put PFCL, shift the fluid to the periphery, and then drain from the pre-existing break. So in many ways, just to keep the posterior pole stable, just to flatten the retina, I think PFCL is a great tool, and people should not be hesitatingly using it. It's something that one can use it for a lot of cases.
And I think the cost is not an issue today. So I would use, frankly speaking, I also use it in virtually every case.
Yeah.
And I use it to make sure I drain from the posterior break, from the break, instead of making a
yes,
very
absolutely.
Yeah. So though that's part of the thing. But one thing I want to ask you, what Steve Charles keeps talking about, do you use that? Using PFCL as a long-term or intermediate-term tamponade?
Not for the indications he's saying. I do use PFCL postoperatively in certain kind of bad trauma cases, or where you have choroidals and some subretinal hemorrhages. After a traumatic, after a repaired case of a perforating injury, and you're operating and it's like badly mutilated. So I keep it there, do a good laser, and go back after 20 days, and the eye is very quiet, nice. And so in a certain group of cases, I do use that, but I don't think I've used it for what he says, that for any normal detachment which doesn't have PVD, you put it, then leave it, then go back. I wouldn't do that. So I think I'm not sure. In fact, I've seen a lot of younger people here who have done it, and I've had patients who've come back with PFCL inside with giant tears.
Yes,
they've been left, and then everything is gone back. So I'm not sure. See, in his hands it will work because he's at a different level. His experience is so much that he kind of knows, but I don't think it is something that can be told for everybody to do. I wouldn't recommend.
Not to take it lightly. I think that should be the message, because everyone will be seeing those videos and then saying, "Let's do it." So not to be taken lightly. Yeah. Yes, it's another procedure which may be considered in extreme cases, but not before that.
Absolutely.
Dinesh sir, just to add the point, during that time when that paper was published in 2013, the midterm PFO for the inferior retinal detachment. In fact, I was very keenly there for CRI for a month. Charles Retina Institute, where Eric Sigler was the fellow who was writing. What they found out was these PFCL globules, which were left for a long time, the macrophages had engulfed it. So the inflammation had actually increased in these cases, and the chances of glaucoma were also very high in these cases who were left for it. That was the side part of that story, which I just realized that. So
that's another thing to keep as a warning.
The inflammatory components, the rays of the glaucoma, and when they did that histopathology and all those electron microscopy, they found out the macrophages engulfing those small PFO bubbles, which had unfortunately entered into the AC. So all these things, I think, has to be confirmed.
Srinivas.
Do we have any questions from the audience?
Dinesh?
Yeah.
You see, this concept of leaving behind PFCL for inferior retina is becoming more and more popular nowadays. I agree. Initially, people used to have this, inflammatory like Shrinivas was saying. But I think a lot of people are doing this procedure now.
I'm only saying that don't take it lightly.
Yeah, I think it has to be done. I mean, if you exactly know your purpose,
you're
for
stuck,
how many days, it is all right, I guess. But it's not something that magically is going to clear up things for you, is what I feel. And
maybe if you're stuck, you can use it as a temporary solution to give you time, but not as the ultimate routine method of managing the things.
Even otherwise, see, in our countries, even just the logistics cost of a repeat surgery within 10 days, 15 days, and all is going to be extremely difficult. It's not going to be easy, because you have to do the same vitrectomy again.
Yeah, I just wanted to know whether from the audience we have any questions. We've been asking questions to you and discussing.
Actually, we're enjoying the discussion so much, and I must tell you that there were 13 questions from the audience, and in this very discussion, all the questions have been answered back to back. I'm going on tick, 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 tick.
So that's wonderful.
This is a very interesting discussion, and thanks to all four of you, because you have covered all the questions without me asking anything.
So Lalit, I request you to conclude the session, and thank you, Manish.
Thank you so much, sir. All of you.
Repeat surgery.
Sorry.
I think we are losing Lalit and Manish. I think it was fantastic to have you over here. Wonderful videos.
I think Rolika, Manish.
Yes, sir.
Manish.
Yes, sir.
Let's say your voice is breaking, actually. Yes, sir. Yes, sir. We can hear you now.
No, Manish.
Yes,
our concept in iFocus is that.
We'll wait for sir.
Can you hear?
I'll tell you what. Shut off your video
and the wonderful videos.
The audio.
On behalf of the entire CFS team, we would like to thank you and hope to see you very soon physically. Okay?
Absolutely, sir. Very soon, and great to see all of you together. And as I said earlier, also thank you for having me here, Santosh. Thank you so much, all the CFS team. And it's been a pleasure talking to all of you.
Looking forward to seeing most
of you in Mumbai, I hope.
Maybe. And I hope you enjoyed presenting, enjoyed hearing me, and I'm sure the audience enjoyed it.
Thank you.
Rolika, thank you very much. As usual,
Thank you.
And the rest of the iFocus team. And
Yes.
Lalit, of course. Actually, Lalit is the one who holds this whole thing together. At least the Retina sessions, he's held together for more than 3 months now, you know.
Wonderful.
Or koi ho na ho, he's always there. Main hu na.
Wonderful.
I think today is a special day when all three of them are there and they're so excited like kids, Manish, with all your videos.
No, it's been a great session and always fun to be with all of you. Excellent.
Thank you so much, everyone, for the wonderful session and the discussion, of course. It was one of the best discussions we have had. And next lecture will be on May 27th with Dr. Shrinivas Joshi, sir. And he'll be talking on artificial retina, new frontiers, which will be our last retina lecture. And it has been a wonderful session. Thank you so much.
Shrinivas, make sure you show that video of that subretinal hemorrhage post-buckling drainage. Yeah.
But it's a different topic this time. It's of artificial retina. Then I have to show where we try to put a retina and then the subretinal hemorrhage or the choroidal hemorrhage started happening.
All right.
And thank you, Manish, for your book is wonderful. I think everyone should go and see that book. It focuses on something even more important than our individual careers. It focuses on our life. Because basically we are all in this precarious balance and we need to maintain this balance in life. We need to maintain this balance on the earth. And I think that's very beautifully captured in his book. And
thank you very much.
That's the way we need to go.
Really encouraging hearing it from you. Thank you so much. All right.
And thank you. Last of all, thank you to Santosh for having this wonderful series of sessions. I think it's a wonderful experience for the postgraduates who come here, and it's something that you've saved for posterity for them. Thank you very much.
3 months of retina. 3 months of retina. I think it must be a Guinness record now. But anyway, it's like a library. Anytime we can go in and see through those videos. I think that's the best part of it. I really
thanks to all of you for creating that library, sir, and thanks to Santosh sir for coming up with the idea. Thank you, everyone.
Bye-bye.
All right. Okay.